चलें स्टार्ट करते हैं ठीक है ओके बिस्मिल्लाहिर्रहमानिर्रहीम today's topic is on the inpatient management of hyperglycemia, the clinical practice guideline. This is a vast topic, and I thought it is very important that now once you have learned about the types of insulin and how to make insulin regimes, now one should learn how to manage insulin management or hyperglycemia management, in fact, in the hospital setting when the patient is hospitalized. The objectives of today's lecture would be the rationale for glycemic control in the hospital. I'll briefly go through a few evidence-based slides. Overview of diagnosis and treatment of strategy of hyperglycemia, hyperglycemia management in hospital, and management of inpatient hyperglycemia in special situations. So what is the rationale of having good glycemic control when the patient is hospitalized? There is clinical importance of glucose control in the inpatient setting because then there is a financial impact of inpatient glycemic control. Strategies for achieving glycemic control would depend on where the patient is. So it can be a critical care setting, which has a different management strategy. Non-critical care setting, special situations like enteral nutrition, total parenteral nutrition, and more, like patient can be on steroids, on infusions. And then finally, we want a good glycemic control, but we have to avoid hypoglycemia in the hospital setting. So coming to the clinical importance for glucose control in the inpatient setting. The key points are that approximately 30% of hospitalized patients have blood glucose values more than 180 milligram per deciliter. And as the glucose levels rise, so does the mortality risk, as well as the risk of dehydration, hypotension, eventual renal shutdown, poor healing of any wound, for example, and impaired immune system function. If, for example, if a patient is hospitalized for sepsis or septicemia and needs a good glucose control for the good immune system to function. Another 6 to 7% of patients have glucose values in the hypoglycemic range, that is less than 70 milligram per deciliter, and they are at the risk for neuroglycopenia, brain dysfunction, and cardiac arrhythmias, which can again prove fatal in vulnerable populations. So you see, we have to keep these points in mind to understand the importance of normal glucose levels when a patient is hospitalized for any reason. When we talk about the intensive care unit, what is the relation of hyperglycemia with the outcome of patient who is in the ICU setup? So you see, as the glucose values rise, the mortality doubles, triples, and quadruples with the range as described. And this is evidence-based, clear-cut in rise in mortality. And special patients like those who are post coronary artery bypass graft surgery, the rise in blood glucose is clearly linked with the cardiac related mortality. You can see that as the blood glucose is rising above 200 here, over here, the green boxes show the cardiac related mortality, and the orangish box show the for non-cardiac related. So even non-cardiac related mortality is increasing, but here we are talking about special people who are post CABG surgery. So it gives a lot of impact to them, really. How do you manage hyperglycemia in the critical care setting? There are a lot of factors to consider, as you can see in the picture as well. Multiple infusion pumps, multiple monitors, multiple parameters to look into, and there can be mishandling of these parameters and malfunctioning errors. So a lot of things has to be kept in mind when you are assessing a good glycemic control in a critical care patient. As we've just gone through previous slides, that definitely hyperglycemia is associated with high mortality. It is an independent marker of ICU related mortality. And if we compare these three type of patient population, as you can see here, someone who has no deranged blood sugar, the in-hospital mortality rate in an ICU setup is just 1.7%, and it is doubling in someone who is known diabetic, but perhaps the blood glucose is controlled in them, but still the mortality is rising. And someone who has been newly diagnosed and is definitely, having high blood glucose levels because they are newly diagnosed, so the mortality rate is like shooting high to up to 16% here according to this research. So what really happens that when someone who is admitted in a critical care setup, there is an illness, okay, that illness, whatever the cause, for example, stroke, MI, infection, pneumonia, or sepsis, that illness, the cause of that illness leads to stress-related hyperglycemia. Okay, so the stress hormones are released here, cortisol, epinephrine. They lead to multiple effects. On the one effect is to decrease the glucose uptake, others to increase the glucose production from the liver, and both lead to increased blood glucose, increased fatty acid in the blood. And on the other hand, there is lipolysis going on because of the stress related catabolic effects. Then all is this leading to hyperglycemia, hyper ketonemia. In fact, the fatty acids rise and they can ultimately lead to high ketones and ketoacidosis. So then how the on the other side, this stress again leads to more exacerbation of illness. The high glucose in the blood, the high fatty acid, is responsible for the hemodynamic insult, electrolyte loss, oxidative stress, myocardial injury, hypercoagulability, altered immunity, decreased wound healing, more inflammation, more inflammatory responses in the body, and decreased endothelial function. So what happens? This again leads to more stress, all right? More stress, more illness, and again more hyperglycemia. So vicious cycle goes on. And illness exacerbates, illness leads to stress, stress leads to more illness. So this is how it goes. Now, what does the guideline says? There are many guidelines, you all know. They all have put in their mind to, give a treatment threshold, give a target glucose level for the special these type of population, define what is hypoglycemia. And this is a summarized table where different types of guidelines have put these target levels, but if you look into them, most of them have a treatment threshold above 180. Although, because now these are very ideal setups from where these guidelines have been made, and they have taken the trials and meta-analysis into their consideration. But if we just take our setup, our local Karachi-based or Pakistan-based setup, we can say, and in the government hospital or even in the private setup, we say that we don't want blood sugars above 200 at least. But here the proper treatment target threshold is 180. And the target glucose level should be like 140 to 180 according to the American Association of Clinical Endocrinologists and American Diabetic Association guidelines. And they have defined hypoglycemia less than 70. Mostly we follow these guidelines, so that's why I'm just stressing on one of them. But you can see they are almost close to each other in the rest of the guidelines as well. So just keep these things in mind when you are, trying to manage a patient who is in the ICU setup. Then what are the indications for intravenous insulin therapy? When the patient has diabetic ketoacidosis, obviously there is no other option other than, have to give an intravenous infusion form of the insulin treatment. Then non-ketotic hyperosmolar state, both of them are the hyperglycemic emergencies. Critical care illness, which can be surgical, which can be medical, and patient is not well enough to, eat or to go through the typical normal life, day-to-day life in that hospitalized setup. Post-cardiac surgery, as I've already explained in the previous slides, myocardial infarction or cardiogenic shock. A patient who is type 1 diabetic and is in the NPO status for any reason, um, a pregnant lady who is in labor and has to undergo delivery, glucose exacerbated by high dose glucocorticoid therapy. In the perioperative phase, again, when the patient is supposed to be kept NPO for a certain time, and which can be, variable as planned. After any organ transplant, because sometimes patients are on steroids and immunosuppressives and are not eating well again, so IV insulin treatment is usually helpful for them. Total parenteral nutrition therapy as well. So these are the main and important kind of indications for IV insulin therapy in a hospital setup. Now, coming to the specific ACE and AD8 recommended target glucose levels in ICU patients, I've explained this earlier as well, and these are just to, go through them quickly. Starting threshold is no higher than 180, according to them. Once IV insulin is started, then the glucose level should be maintained between 140 and 180. You have to aim this target level. Lower glucose targets, like between 110 to 140, may be appropriate in selected patients, and targets less than 110 and more than 180 are not recommended. So, the box down here, the table, the tabular box can explain these values very well, which you have to keep in mind. So, the green is always the one which you have to go with, but sometimes this acceptable level of lower targets are required in certain patients. Sometimes you may have experienced or you may come across that the surgical teams usually want these types of tighter glucose control in their patient for adequate and better wound healing. So, but you have to make your own judgment looking into the whole patient scenario and then decide about their target glucose. So, what are the components of IV insulin therapy? Concentrations should be standardized throughout the hospital. It shouldn't be like ICU has a certain standard and general ward is different, and then we have different standards going on in the operation theaters and so on. So it should be standardized throughout the hospital. Everyone should know that a regular insulin in concentration of 1 unit per ml is supposed to be used for any type of insulin infusion setup. Accurate bedside glucose monitoring should be done hourly or every 2 hours if the patient is stable, and it depends on the diabetes team who will guide further as to what to do. Potassium should be monitored and given if necessary. Regarding the blood glucose monitoring, specific situations rendering capillary tests inaccurate, requiring intra-arterial or venous sampling rather. Now, these should be kept in mind. These are actually the caveats when blood glucose monitoring through capillary test can misguide you. And what are they? Shock, hypoxia, dehydration, and the blood flow is not very good to be reliable. Extremes in hematocrit, it can give you a concentrated or elevated blood sugar reading. Elevated bilirubin, triglycerides, it can interfere with the monitoring setup, and the drugs again, they can also interfere with the setup. So in such, when you have to keep these factors in mind when you are monitoring a patient's blood glucose through the capillary test, that is the bedside monitoring. And sometimes you have to relax, keep a check on or a cross check through the lab arterial or venous sampling to make major decisions. Now coming to the insulin infusion protocol, bedside monitoring worksheet. Now, this is something very important topic, a very important topic, which is missing in several hospitals, several wards, and many of the setup does not have the concept about a worksheet or a protocol. So every hospital can develop its own worksheet or protocol, but there are certain famous protocols available on the internet, and you can Google them. And they are mostly American based, states wise. So they can be adopted, and they need to be taught to all the internists and medical residents as well as fellows and the staff, nursing staff looking after these patients, and so that an unanimous or a smooth or a similar kind of protocol is followed everywhere, and no one can actually make an error regarding blood glucose management or sugar management in a particular patient someone who is on insulin infusion. So you must select the patient as per the criteria that I have described earlier, that this patient require insulin infusion therapy. Mostly the blood glucose thresholds are taken as more than 200 or 180, for example. And then therapy goal is blood glucose 140 to 180. The protocol usually consists of the following steps. Give bolus with regular insulin per intravenous push or intra-IVP. Infuse a regular insulin infusion. Monitor blood glucose level hourly. The infusion dose is titrated hourly, and the titration is based on a sliding scale protocol. So these are just the steps that as to what exactly you have to do. Now, how to do? So the first step was to give a bolus dose, right? So bolus dose, how to calculate that? Bolus dose calculation. Check the current glucose level and then divide that by 100. The calculated dose is rounded off to next 0.5 value or a whole number. Now here is the example. For example, if you check the blood glucose, that is 250. Divide this 250 by 100, you get 2.5. This is the bolus dose that you have to give by intravenous push, okay? So the bolus dose is regular insulin 2.5 units intravenous push. And then comes the insulin infusion. Insulin infusion concentration should be prepared at 1:1 ratio. 1 unit of insulin in 1 ml of normal saline. Example, regular insulin 100 units should be diluted in 100 ml of the normal saline. Use only an infusion pump when administering an insulin infusion to prevent the free flow. Because when you are using those drips with their dial flows, there's a chance that a rapid flow will take place and the patient can suddenly develop hypoglycemia. And they're not very easy and more technical to manage. The advanced technology should be utilized and the pumps should be used. Safe insulin infusion rate range is between 0.5 to 20 units per hour. Verify the physician order if the dose does not fall in this range. So anyone in the critical setup or in the non-critical setup requiring IV insulin infusion therapy is requiring more than 20 units per hour, then you should check with the team, check with everything, call the main physician, call the diabetes team, or look at the patient, look at the whole treatment setup around him or her, see the tubing, see the connections, see what he or she is eating, any new drug added, because requiring more than 20 units per hour is like a very high insulin resistance in that patient. And you have to be like very careful and conscious that why the patient is requiring such a high insulin dose. The initial infusion dose is the same numerical value as the bolus. So in the previous slide, it was 2.5 units IV push. So that will be the 2.5 unit per hour, the rate would be. Now here, for example, the bolus is 3 units, then the infusion rate would be 3 units per hour. That is 3 ml per hour as per the preparation of the concentration according to this first point. Okay. So moving on, this is a Portland diabetic protocol, which is followed in our ICU setup in Dow University. And this is one of the important protocols which has been adopted there. And this is just an example to show how the blood glucose range is taken. And I mean, you can see the table here. This is a sliding scale, right? And you are changing the bolus units are given here, and the change in units is given on the other side, which depend on your blood glucose range. I mean, I just wanted to give you a glimpse as to how it looks. You can go through this website, as you can see here, a link here, and you can check the whole protocol in this article. The reference is mentioned below. This is another insulin infusion sliding scale. This has been adopted from Yale's University, USA, and that is it is also being followed in the Aachen University, and this is also quite complicated, and the whole, you have to teach this protocol to all the physicians taking care of the patient. In fact, you have to teach this protocol particularly to the nursing team and the diabetic team who is involved in the hyperglycemia management in the whole hospital. So this is an example, again, a worksheet kind of thing. Now coming to the topic where you have to transition from the IV to sub-Q insulin. So far, we've learned the IV insulin infusion therapy, um, which is what are the indications, how we start them, how to run an insulin infusion in a particular critical care patient, for example, and what are the mortality associated with the critical setting when there is hyperglycemia. Now, coming to a very important topic, that is this transition from the IV to sub-Q. Uh, Now, here, important points here are considerations. When do you consider that, okay, now is the time that IV should be stopped and let's begin with the sub-Q? Will the resolution of illness or illnesses or change in concomitant therapies reduce insulin needs? You have to check that. You have to assess that. You can be called, okay, now the patient is stable. Come on, doctor, and now shift the patient to sub-Q. That's what happened. That's what I do in my practice. But then I have to see, okay, now the blood parameters are not good. The leukocyte count is still high. The patient is still not very conscious, not eating well. The urine output, for example, is not very good. Patient is requiring fluids, and so on. I mean, different factors have to be looked into, which you have to make a decision about, and then decide, okay, now this is the time to switch or not. Like, for example, what are the concomitant therapies? Is the patient still requiring glucocorticoids? And if so, what dose? And what has been the effect of glucocorticoid on the blood glucose level in this particular patient? What are the ionotopes? The person maintaining hemodynamics or not? Is he requiring vasoconstrictors or not? Because of the short half-life of the IV insulin, sub-Q basal insulin should be administered at least 1 to 2 hours prior to discontinuing the IV drip. So as soon as you stop the infusion, the insulin, the half-life of the insulin, because the short half-life, it vanishes from the blood. Okay, it gets metabolized quickly, and soon you will get another reading of the blood sugar, which will be from the normal range to sky high, and then you will be confused. You may start the infusion altogether again. So what you have to do, you have to do overlapping. This is the concept of overlapping. You decide that this will be the sub-Q basal insulin dose, you give the dose, and then stop the infusion rate after 1 or 2 hours, because depend on what basal insulin you are giving. Those insulins which have the onset of action in 2 to 3 hours, the infusion rate should be stopped around 2 hours. But those which have a higher onset, I mean late onset of action, like for example 4 hours or 5 hours, then you may continue the drip until that time. So it depends. You should know the pharmacokinetics and dynamics, as I've explained in my earlier lecture. Now calculating the subcutaneous insulin dose. Okay, you have decided now we have to switch this patient from IV to sub-Q. Now what will be the dose? So establish the 24-hour insulin requirement in that particular patient by extrapolating from the IV insulin dose required over the previous 6 to 8 hours if stable. Now remember this bracket, if stable. This is very important. Stable means the target range, the target glucose that you have decided in that particular patient. Like in the guidelines, we've come to know that it is between 140 to 180, but you may individualize it from patient to patient. Sometimes, for example, if the patient is very old, very lot of comorbids, you don't want to give a very tight control. Okay, it can be a little higher. So if you have to see that in the previous 6 to 8 hours, that stability has been achieved or not. If not, then you may actually say, okay, continue the infusion for a couple of more hours. Once you've achieved that target in that 6 to 8 hours, calculate the 24-hour dose from that 6 to 8 hour total dose. So how do you do that? You multiply the dose in the you basically add the dose in the 6 to 8 hours, multiply that with 4. So you get an answer of 24-hour insulin. For example, in the last 6 to 8 hours, patient required 20 units. What will be the dose for the 24 hours? So you would multiply 20 multiplied by 4. That is 4 twos are 8. Okay. So 80 units. 80 units in the 24 hours. Now that 80 units is the total daily dose. You take 60 to 80% of total daily dose, divide that into how do you give that? Give one half as the intermediate acting or long acting insulin for basal coverage, and give other half as a short acting or rapid acting insulin in the divided doses before meal. So basal bolus regime. So you take 60 to 80% of that total dose. You don't have to give as it is. Remember, the patient has required IV insulin infusion during stress, during critical illness. So the sub-Q insulin dose requirement may actually be low. Now, what are the proposed predictors for successful transition from IV insulin infusion to sub-Q insulin therapy? What are the factors or what are the patient categories who would most likely be successfully transitioned and would continue to be on sub-Q insulin? So, as you can see on the left side of the screen here, it is the factors are on those who underwent uncomplicated CABG surgery and or valve surgery and discharged from the ICU extubated. That means they were stable. They are taking liquids, regular meals. They are following the diabetic diet as advised. For example, an ADA-associated diet. They have stable renal function. He observed for 6 to 8 hours before breakfast to determine basal insulin requirement with type 2 diabetes or hospitalization-related hyperglycemia. That means they are on the lower risk side, receiving less than 2 units per hour insulin infusion with concomitant blood glucose of less than 130. So a good control type of, hyperglycemia here. Basal insulin dose has been less than 48 units per day while receiving insulin infusion. So when you calculate the total daily dose through the method that I've described previously, the requirement has been less than 48 units per day. So these are the people who would likely to be successfully, continuing the sub-Q treatment as you will prescribe it. Now, what factors would make it more jittery for us to say, okay, don't stop it, don't transition now, maybe a little more? Those who underwent complicated heart surgeries at higher risk for mediastinitis in ICU setup, receiving pressors require intra-aortic balloon pump, receiving corticosteroids, blood glucose more than 130 while receiving insulin infusion, with type 1 diabetics. So type 1 diabetics are also at higher risk category in such management risks. Basal insulin dose projected to be more than 48 units per day while receiving insulin infusion. Basal insulin infusion rate has been more than 2 units per hour to maintain the blood glucose less than 130. So if you see, they are mostly the critical patients, especially those related to heart surgeries or heart failures and type 1 diabetic and requiring higher insulin doses. Now coming to the management of hyperglycemia in the non-critical care setup. Now for that, first and for all, you must understand certain terms and you should know their definitions very well. What is hospital hyperglycemia? What is stress hyperglycemia? When do you say A1C values of significant to consider in a patient? What is hypoglycemia and what is severe hypo? So hospital hyperglycemia is the same as when we define random glucose more than 140 in the outpatient basis to define diabetes or impaired glucose tolerance. So any blood glucose level more than 140 is hospital hyperglycemia. Stress hyperglycemia, elevations in blood glucose levels that occur in patients with no prior history of diabetes, and A1C levels that are not significantly elevated. So the patient has arrived in the hospital. You check the hemoglobin A1C, it is less than 6.5%, not fitting into the diabetes diagnosis. But the blood glucose is elevated. So you can say, okay, now the patient is under stress, or maybe the stress factors are going on, that's why. So you can say, okay, this is stress hyperglycemia. When the A1C value is definitely more than 6.5, this is suggestive of prior history of diabetes. When you label the patient as, okay, this is a newly diagnosed diabetic, okay. And then hypoglycemia is less than 70, but severe hypoglycemia is less than 40. So once the patient develops blood glucose less than 70, you have to be on alert that so as to avoid any hypoglycemia associated brain injuries and so on. Recognition and diagnosis of hyperglycemia and diabetes in the hospital setting. So what should be done? This algorithm or this protocol should be present in every ICU, every ward, emergency unit, operation theater, and so on. Everyone should know about what to do about hyperglycemia or diabetes. Upon admission, assess all patients for a history of diabetes. Rule of thumb, universal, okay? Obtain laboratory blood glucose testing and then go accordingly. If the patient has no history of diabetes and the blood glucose less than 140, then just initiate the point of care blood glucose monitoring according to the clinical status, maybe once or twice a day. That would be enough to keep a watch on that. Why do you want to have a watch? Because there is an option of stress hyperglycemia that you have to manage. Then, if the patient does not have any history of diabetes and the blood glucose is more than 140, then again start the point of care blood glucose monitoring for 24 to 48 hours and check the hemoglobin A1C meanwhile. If the A1C is more than 6.5%, then continue the blood glucose monitoring as per protocol for that patient for diabetes management and hyperglycemia management. And if the patient has a history of diabetes, go for A1C management straight away. So sometimes, what happened when I visit the hospital, in a patient in the hospital, and for example, obs and gynae team calls me, or sometimes the orthopedic and urology teams call me. So I have to tell them that please check the A1C in this patient. But this should already be done by them because this is diabetes is so much prevalent. Every fourth person is diabetic in my country, in our country. So this should be kept in mind that any person coming in the hospital can be diabetic. So this type of history, this type of um, uh, this type of triage for diabetes should be done right at the time of admission straight away. Uh, Now coming understanding about hemoglobin A1C for diagnosis of diabetes in the hospital. Obviously, A1C more than 6.5% indicates diabetes. Implementation of A1C testing can be useful. It assists with the differentiation of newly diagnosed diabetes from stress hyperglycemia. It assesses glycemic control prior to admission, that what has been the control since the patient arrived, because now you may have to change certain medicines. Patient may go MPO, patient may need insulin or not. So this will give you an answer. Facilitate design of an optimal regime at the time of discharge as well. Okay, now you may say that the previous A1C was not very good. Now patient is going back home. So let's give him a good treatment regime rather than what he was taking before. But there are certain caveats to using A1C alone for diagnosis of diabetes in dealing with that. So values can be altered with several conditions like hemoglobinopathies, for example, sickle cell disease, high dose salicylates, hemodialysis, transfusions, iron deficiency anemia. So these conditions can give you false picture of A1C, which can be high or low depending. I'm not going into much detail, but you have to keep in mind that any factor which affect the hemoglobin itself, and then there are certain drugs, uh, then these conditions can alter the picture of A1C and make it unreliable in that state. So in such condition, you may have to rely on the point of care blood glucose monitoring only in that particular patient. You will not go for any OGTT type of testing in the hospitalized setup. So, what are the glycemic targets in non-critical care setting? Maintain fasting and preprandial glucose level less than 140. Modify therapy when blood glucose is less than 100 to avoid any risk of hypoglycemia. Maintain random blood glucose less than 180. So you see, you are trying to maintain the blood glucose between 140 and 180. You don't want a fasting blood glucose target between 90 to 130 as in the outpatient setting as defined by ADA. The hospitalized, even non-critical care setup does not allow you to do that, because in the hospitalized setup there are always certain stress factors to play, and have to avoid the risk of hyperglycemia in such patient in the in the process of having stringent targets and stringent control. You may actually put the patient at risk. But again, you can take you can decide from individual patient. If the patient is stable, you can go for certain tighter glycemic controls like 110 to 140 or 110 to 180 as described previously. Less stringent targets may be appropriate in terminally ill patients or in patients with severe comorbidities. As I said, sometimes I have to, decide, okay, this patient can have a blood glucose target between 200 to 250 rather than, less than 180, depending on the terminal illness. How do you monitor the glycemia in the non-critical care setting? Okay, the point of care testing has a very good role here, and it is the preferred method for guiding ongoing glycemic management of individual patients. Timing of glucose measures should match patients' nutritional intake and medication regime, and sometimes you have to take into account the NPO status of the patient and what are your aims for a particular patient's glycemic control. Recommended schedules for POC testing are before meals and at the bedtime in the hospitals in patients who are eating. Every 4 to 6 hours in patients who are NPO or receiving continuous enteral feeding. So remember this, the before meals and the bedtime is the main timings, main schedule. And every 6 hours in NPO or those receiving enteral feeding, because that can be matched with the sliding scale protocol. Medical nutrition therapy is an essential component of the glycemic management program for all hospitalized patients with diabetes and hyperglycemia. Providing meals with a consistent amount of carbohydrate can be useful in coordinating the doses of rapid-acting insulin to carbohydrate ingestion. So it is always useful to call on the nutritional team and tell them this diabetic patient modify his or her diet so that it can help you decide about the insulin doses or whatever therapy you're planning for the patient. So, what to choose for treatment in treatment of hyperglycemia in non-ICU or non-critical setup? We know in critical setup, insulin is the answer, mostly in the form of infusion. But in the non-ICU, you can have certain other options, but um, they have their own issues to deal with. So there are options like sub-Q insulin, recommended for most medical and surgical patients. Then there are options of oral anti-diabetic drugs, not generally recommended, but still we use them in certain population. And continuous IV infusion can be used in selected medical and surgical patients. So even in the non-critical setup, there are certain medical surgical patients who would need an IV infusion because their hyperglycemia would be so high to put them on hyperglycemic emergencies, that is DKA and HHS, or there can be a risk of developing dehydration, kidney shutdown, and poor management of whatever illness the patient is admitted with. But the oral anti-diabetic drugs sometimes are usually not encouraged in a hospitalized setup. So try to make a sort of an insulin regime for such patients so that they can be quickly recovered and earlier discharge is possible. Glycemic management strategies in non-critically ill patients. Insulin therapy is preferred regardless of the type of diabetes. Discontinue non-insulin agents at hospital admission of most patients with type 2 diabetes with acute illness. Use scheduled sub-Q insulin with basal, nutritional, and correction components. So basal is for the long-acting, nutritional is the bolus dose, and correction component usually come from the sliding scale. Modify insulin dose in patients treated with insulin before admission to reduce the risk for hypoglycemia as well as hyperglycemia. You have to assess whatever the dose patient taking at home. Do I have to reduce it when the patient is admitted, or I actually have to increase because the patient is not on good control at home as well? Avoid prolonged therapy with sliding scale insulin alone. In fact, the ADA does not recommend sliding scale insulin therapy as the treatment strategy for any diabetic patient in the hospitalized setup. Okay, remember, it is just to help you for correcting the requirement of the insulin for the whole 24 hours, but it is not the only treatment or the best treatment anyway. Talking about the non-insulin therapies, time action profile of oral agents can result in delayed achievement of target glucose ranges in the hospitalized patients. As I said, that this may not help in quicker recovery. So sulfonylureas, for example, they are major cause of prolonged hypoglycemia, so they should be avoided. Metformin is contraindicated in patients with decreased renal function, use of iodinated contrast agent, and any state associated with poor tissue perfusion, like, for example, congestive heart failure and those with sepsis or any other inflammatory problems. So mostly the patient who are hospitalized, they are not well, they are sick, they have illness, they have some sort of inflammatory processes going on, and tissue perfusion might be affected. So you cannot take the risk of actually starting metformin in such patients. Thiazolidinediones are associated with edema and congestive heart failure. So again, you don't want to give them. Alpha glucose inhibitors, they are weak glucose lowering agents. They would not give a good glycemic control, and you cannot waste time with that. Pramlintide and GLP-1 receptor agonists can cause nausea and uh, exert a greater effect on the postprandial glucose. So therefore, insulin therapy is the preferred approach. Now, what are the sub-Q insulin options? Basal insulin, through this will control blood glucose in the fasting state. The options are like Detemol or Glargine and NPH. Nutritional or bolus insulin, prandial insulin, it blunts the rise in blood glucose following nutritional intake. Meals, IV dextrose, enteral, parenteral nutrition, and the options are rapid acting, aspart, glulisine, lispro, short acting, regular. The correction insulin it's supposed to correct hyperglycemia due to mismatch of the nutritional intake and or illness related factors and schedule insulin administration. So see, I have stressed and defined here again with what does the correction insulin really means, and this comes from the sliding scale that you make for that particular patient. One should know the pharmacokinetics of insulin preparations. I will not go into much detail of these types. The different types of insulin have different types of onset, different peaks and duration. I've already explained this in much detail in my previous lecture, but then these are the ones, I mean, they have to be kept in mind when you are managing patient in a hospitalized setup. And that is the reason how you manage, that is the way how you assess the management and decide what to do in a particular patient. Again, the pharmacokinetic time action profile of insulin products. You can see here how the rapid acting insulin is working with peaks coming to the peaks and the rapid control, whereas the intermediate has a near 12 to 14 hours effect, and the basal long acting one have 24-hour profile. How do you initiate insulin therapy in the hospital in the non-critical setup? So obtain the patient weight in kilograms, calculate the total daily dose, which can be like, for example, 0.3 unit per kg. Choose the dosing schedule in that particular patient. Uh, Either give 50 to 60% of the total daily dose as basal insulin, give 40 to 50% of the rest of the total daily dose as nutritional insulin, and use correction insulin for blood glucose that goes above the goal range, and adjust according to the results of the bedside glucose monitoring, and adjust for the NPO status or changes in the clinical status. So the best regime here, I hope you've got the message here, the single message, and the confusion is waned away, that the best dosing schedule is the one with basal insulin and bolus. So basal bolus regime is really ideal, and it avoids any hyper and hypo issues, and give the patient a quick recovery time and is easily manageable. But you can always alter, and sometimes there are variations. You can individualize therapies, and that requires a specialist input. But this is the real message for all the freshly graduate and postgraduate students. They can manage through this particular regime. um, Calculating the total daily dose. So how do you calculate? What is the criteria? I have given you an option of zero point 0.3 units here, but maybe there are other options like 0.2 to zero point 0.3 unit per kg if age is more than 70 years and the GFR is less than 60 milliliter per minute. So you have to keep the age and the renal function in mind when you are deciding the total daily dose. It's very important. So this is a lower dose, zero point 0.2 to zero point 0.3. 0.4 unit per kg can be taken if the age is less than 70 years, if the GFR is more than 60 ml per minute, and the blood glucose is also between 140 to 200. But a tighter control can be achieved by using 0.5 unit per kg if the age is less than 70 years, GFR is good, that is more than 60, and the blood glucose is high, that is more than 200. So you see, it depends on the whole patient. It is a matter of numbers. It is the game of numbers, no doubt, but where does the number come from? The patient, the age, the renal function, the clinical status, the illness, everything is important to know. You really have to take a good history of that particular patient, good examination findings with you to understand what the patient is to decide about this all. Insulin therapy in patients with known type 2 diabetes. So what do you do? Discontinue non-insulin agents on admission. For insulin naive patients who have never used insulin in the past, start with total daily dose by calculation method as I've just described. Lower doses in the elderly and patient with renal insufficiency, remember, as I've described. Previous insulin therapy, if the patient is already on insulin therapy, so this was about insulin naive, but someone who has is already on insulin therapy at home, then reduce the outpatient insulin dose by 20 to 25%, depending on what glycemic control has been in the last 3 months too, by checking the A1C. Again, what does the guidelines from professional organizations have to say for non-critically ill patients? So again, we take recommendation mostly from the ACE and ADA organization, and in them the treatment threshold is again 180, not different from the critical setup, and the pre-meal target here is 140, and they define hypoglycemia to be 70. So nothing really much different. And again, endocrine society practice guideline also speaks the same, and this has been updated since nice sugar trial as well. Nice sugar trial was basically to assess the intensive insulin treatment regime versus conventional regime in critically and critical or and non-critical is in fact the hospitalized patients, so they apply to both. So these are the recommendations. So again, the description here, the pre-meal glucose targets less than 140. Random blood glucose should be less than 180. To avoid hypoglycemia, reassess insulin regime if blood glucose levels fall below 100. And occasional patients may be maintained with a glucose range below and or above these cut points, depending on your judgment, depending on the diabetologist team and the judgment of the physician. So if you see the non-ICU patients have almost the same glycemic targets and same treatment thresholds and nothing much different, but there can be variations, and the insulin regime, insulin management is a bit different. Now, I think this is a very important topic without which the whole inpatient management of hypoglycemia would be incomplete. There are certain special populations in the hospitalized setup which you have to take care of. For example, patient on steroids, right? Um, these are the adrenal glands here for you to have a look into them above the kidneys, and someone is trying to check them during hospitalized setup. Steroid therapy and inpatient glycemic control. Steroids are counter-regulatory hormones, right? They impair insulin action, induce insulin resistance, and they appear to diminish insulin secretion as well. And whenever there is stress, they come up first. Majority of patients receiving more than 2 days of glucocorticoid therapy at a dose equivalent to or more than 40 milligram per day of prednisone develop hyperglycemia. So you can take this 40 milligram per day of prednisone as your equivalent dose equivalent criteria and apply it to whatever type of glucocorticoid therapy is being used. For example, dexamethasone, prednisolone, and so on. If it is more than 40 for more than 2 days, there is a chance that the patient will develop steroid related hyperglycemia. General guidelines for glucose control in such patients. Suggested approach is institute glucose monitoring for at least 48 hours in all patients. Prescribe insulin therapy based on bedside glucose monitoring. For the duration of steroid therapy, adjust insulin therapy to avoid and control hyperglycemia and hypoglycemia. Okay, you have to give insulin in such patients. Remember, most of the oral agents do not stand in such patients. So, steroid therapy in patients with and without diabetes, and what glycemic control you have to do. So, there can be patients who are diabetic and started on steroid. There can be patients who are not. So those without prediabetes or hyperglycemia, or those with diabetes with controlled with oral agents, begin blood glucose monitoring with low dose correction insulin scale administered prior to meals. Those patients who are previously treated with insulin, being diabetic, increase the total daily dose by 20 to 40% with the start of high dose steroid therapy straight away, and then adjust insulin as needed to maintain glycemic control with caution during steroid taper. So you have to, keep in touch with the team whenever you taper down the steroid dose. Please let us know. We have to adjust the insulin dose as well. Coming to the pre-operative recommendations for patients undergoing operations or surgeries. Pre-operative recommendation: patients admitted on the day of surgery, patients on non-insulin agents. For those who are on non-insulin agents, had been on oral therapy at home. Withhold these non-insulin agents the morning of surgery. Insulin is necessary to control glucose in patients with blood glucose more than 180 during surgery. And non-insulin agents can be resumed post-operatively when the patient is reliably taking per orally, and the risk of liver, kidney, and heart failure in such patients are lower. So these factors you have to keep in mind when you are dealing patients who are on non-insulin agents at home. Simple. But for patients who are on insulin, who had been on insulin, there's a difference. So patients on basal or basal bolus insulin regime give 50% of the usual NPH dose that morning on the day of surgery, or 80% of the usual dose of NPH, glargine, or detamir in the night before. So long acting has to be given night before, but the intermediate acting NPH has to be given on that morning, despite the patient being NPO. Remember this because most of the staff and the primary teams are not very, very much satisfied, or they are not very happy to give such type of insulin on the day of surgery. So you have to, they're not very comfortable actually. So you counsel them. The goal is to avoid hypoglycemia during NPO periods, but also prevent pre-surgical blood glucose of more than 180 if possible. Otherwise, the anesthesia team would say to, postpone the surgery anyway, which will be a loss to the patient's financial status and the surgeon's time frame and everything. Patients on premix insulin, that is 70-30 or 75-25 regime, give 1/3 of total dose as NPH only prior to procedure. Only prior to procedure of that particular mixture. Patients undergoing prolonged procedures like coronary artery bypass graft, then hold the subcu insulin and start IV insulin infusion, which will also be needed post-operatively. Obviously, the coronary artery bypass graft surgeries are very complex and prolonged procedures, prolonged surgeries, and sub-Q type of insulins would not have much effect, and then insulin infusion has to be taken on board anyway. Now, very important, and I guess the last topic of my today's lecture, that you have to control and manage hyperglycemia in the hospital, but at the same time, you must avoid hypoglycemia. So patient-specific factors which increase the risk of hypoglycemia in the inpatient setting: advanced age, decreased oral intake, chronic renal failure, liver disease, beta blockers. So a good history, good overview of the case will tell you this. What are the strategies to manage hypoglycemia? Symptoms may include confusion, lethargy, change in mental status, tachycardia, and diaphoresis. So these things can be alarming for staff, for attendants who are around the patient, or for any healthcare professional visiting the patient. For symptoms of hypoglycemia, check blood glucose stat. Immediately ask the staff or nursing staff, whoever is there, to check the blood glucose immediately. For blood glucose reading resulting in 70 milligram per deciliter or less, implement the hypoglycemia protocol. Now, this is something standard which needs to be taught and learned by all the hospital employees, in fact. If patient can take per orally, give 20 grams of fast-acting carbohydrate, like for example, 6 ounce of fruit juice. So availability of fruit juice is quite easy. If the patient can take orally, that would be the best. If patient cannot take orally, or then give 50 milliliter of 25% dextrose as an IV push. We in our practice, obviously, the availability of fruit juice is not very, very luxuriously available. So sometimes we often have given this 25% dextrose per orally to our patients as well, which is fair enough. Check blood glucose every 15 minutes and repeat if blood glucose remains below hundreds. So remember the important and the key point in the protocol of hypoglycemia treatment is to check the blood glucose every 15 minutes and see if it is safely above 100 or not. If not, then you have to repeatedly give this 20 grams of fast-acting carbohydrate or dextrose 25%. Scenarios prompting increased monitoring and possible decreases in insulin dose. So keep these things in mind when someone is on insulin infusion or insulin regime. Then patient who is switched to the NPO status, you may have to alter the insulin regime, decrease the dose, reduction in food intake. Patient is not eating, having nausea, vomiting whatsoever. There is discontinuation of enteral feeding or TPN. There is discontinuation or reduction in the IV dextrose for any reason. And such patient would not require insulin in such high doses. So you have to alter the regime. Timing of free meal insulin if meal disrupted due to medical procedures or patient transport, if that has been changed. For example, if patient has to undergo an ultrasound scan, he or she is kept NPO, did not take breakfast, and unfortunately patient could not have an ultrasound in the morning and still waiting in the queue, and the lunchtime has arrived and the staff comes up checking the blood glucose and giving a sub-Q sliding scale insulin as per requirement. So that will be dangerous. So you have to inform the patient, inform the staff, or that please keep in mind that patient is going for ultrasound and is still waiting for that. So be careful about this scenario. Reduction in the corticosteroid administration is also, as I've explained in detail in previous slides, that would alter the insulin regime of any sort in such patients. Thank you very much, and that is the end of this lecture. We'll see you again.